Bicep tendon. Brachioradialis is here. This is biceps. Yeah. People do it up here.
It's taking away more. When I was practicing this, like, I'm gonna back her head.
He's an oral guy. It's a bad question.
Now I have to say it.
Oh, God.
Jerry, are you gonna be
Today?
I thought you were gonna just make
What, you out of your mind?
Sundays and show us all the things.
Oh, they're very good. You guys can be.
Yeah, just talk your way. Just say, you know, I'm inspecting the joint about from the shoulder down to the finger.
We're gonna fight against your side in a minute.
Right.
Are you positive that everybody's gonna have consensus?
I'll let them know. Because that's my big thing. The rest of them aren't ortho people. The rest of them are primary care people.
Are we okay with saying bilateral?
Intensive care people.
I would do it bilateral.
Yes, in my group, you can ask the preceptor first. Ask them, do you want me to do both sides?
And then if they say yes, you put your said I didn't have to.
No. If they want you to do both sides, you got to do both sides. So, just ask them. Make sure you ask them. Huh? Fun hints? Know your stuff. Know your stuff. All right. We're going to start. This lecture, I think we're booked for 2 hours, but I don't think it'll take 2 hours, so then you guys can go practice your physical exams. This one is disorders of the elbow, wrist, and hand. One thing, I got a lot of emails saying that you filled out the form for it's not a suture kit, I keep calling it the knot tying board. And basically, I guess they're on back order. It won't be in until the fourth quarter, so I'm guessing the fourth quarter is sometime in October. You know, October 4th, all right. So, I mean, we'll have to live with that. The knot tying board is usually used for hand tying knots. So we'll show you how to do that. We have a couple of the boards downstairs. It's for hand tying knots. It's more for surgery because they give you these little cups and you loop it around a hook. And it teaches you to suture down into a hole because sometimes when you're doing surgery, you have to be able to hand tie and suture down into a hole and push it down, push the knot down in with your finger. And then there's usually 2 rubber bands on there as well, and that's for practicing getting the edges to evert. So you'll learn it all next semester, but that knot tying board, unfortunately, they're on back order, so there's really nothing we can do about it. The company gives them to us for free, so you can't look a gift horse in the mouth. And second is, I don't know if everybody heard it, but anybody here, if you had me last week for the SIM patient, I've only gotten 2 soap notes so far. I got Matt's and Angela's. So if you were in one of my groups and you sent it, it's probably lost in cyberspace somewhere. It's not the first time I've had a problem with that. So if you can resend it to me, if you were in my group, I think it was just the morning last week I did. So, okay? All right, going to get started. So we're going to look at the elbow first. The elbow is a hinge joint. It's composed of 3 bones, the humerus, the radius, and the ulna. There's 3 main articulations. The humeral-radial articulation is formed by the radius and the humerus at the capitellum. The humeral-ulnar articulation is formed by the ulnar notch and the trochlea of the humerus. And the superior radial ulna articulation is formed by the proximal part of the radius and ulna. All the articulations are enclosed in one synovial lined capsule. The two main movements at the elbow are flexion and extension, and it occurs primarily at the humeral-ulnar articulation. Pronation and supination occurs primarily at the humeral radial articulation. So if you look at the bones here, here's your humerus, here's the radius here, and this is the olecranon of the ulna that goes into the notch there. There's your trochlear notch back here. This is the coronoid process that articulates with the radius. This is your lateral epicondyle. Over here would be your medial epicondyle. Here's the capitellum up through here. This is considered your radial neck. And this bony prominence here is the tuberosity. So when you're talking about elbow fractures, there's intercondylar and supracondylar fractures. So intercondylar fractures occur when the condylar fragments of the humerus are separated. So it's more common in adults. It's the mechanism of injury is a direct force against the posterior elbow to here. So you land on it like that. So you're going to fall on a flexed elbow. It kind of just jams the olecranon against the humeral articular surface and splits the condyles. Treatment's often complicated, and usually you have to do some type of either closed or open reduction. So these are different types of condylar fractures. You can see this one here comes all the way down to the joint. This one really doesn't go into the joint. They can be T-shaped, they can be Y-shaped, they can be H-shaped. If you look here, here's an X-ray of one. This one comes all the way down into the joint. The classic finding on an elbow X-ray is a fat pad sign. If you see a fat pad sign, this is your fat pad sign, especially posteriorly. That's pathognomonic for a fracture. So you need to know that whenever you're looking at an elbow X-ray. If you see a fat pad sign and still can't identify a fracture, you need to splint them and you need to get a repeat X-ray in 7 to 10 days. You can see here, here's the anterior one, and it's displaced up here. So sometimes when you only have the anterior one and it's displaced, you think of a radial head fracture. When you see it back here, this is probably some kind of intercondylar or supracondylar type fracture that's just not showing up. It can also be just a joint diffusion from a fall or some type of trauma to the elbow. So you get that repeat X-ray in 7 to 10 days. The joint effusion should have started to decrease, and you may not see a fracture, but if there is a fracture there when the joint effusion decreases, then it could have been what's holding the fracture in place, and now you'll see the fracture. So anytime you see that fat pad sign, you always think of an elbow fracture. Supracondylar fractures, they're the most common elbow fracture in pediatrics. You rarely see them after 15 years old unless it's a high impact, high energy type injury. It's most commonly caused by an extension type injury. The complications include injuries to the median, radial, and anterior interosseous nerves. Most of the deficits are neuropraxias that resolve with conservative management. The motor function usually recovers in about 7 to 12 weeks, while the sensory takes up to 6 months. Remember, with nerves, if they get damaged, they heal about 1 millimeter per month, so that's not very fast. Vascular injuries, and that's if they're going to heal at all. Vascular injuries should always be suspected, so you should always, always, always be doing neurovascular exams on any type of orthopedic injury. The most common complication is usually called cubitus varus, which is a deformity with a loss of the carrying angle. So their elbow's kind of in like that, a varus type thing. Could you guys see that? So the elbow angles in towards the midline. The extension type injuries account for 95% of supracondylar fractures. Type 1 is a non-displaced, and its treatment consists of immobilization with a splinter cast with the elbow flexed for 4 to 6 weeks. So you want these people in a neutral position. The elbow should be flexed to 90, and the thumb should be pointing up. Type 2 is displaced with the posterior cortex intact, and the treatment consists of a closed reduction. So you basically, what you would do is with the kids, usually what they'll do is conscious sedation, and you got to pull it back into place, and then you're going to have to pin that. and then you're going to splint them again for about 4 to 6 weeks. In the type 3, it's displaced with both the anterior and posterior cortex disrupted. And again, the treatment is closed reduction, which is conscious sedation, pulling it back into place and splinting it, or open reduction, where you have to go to the OR, open it up, and pin it. The type 3 fractures have a higher significance for displacement and a higher incidence of neurovascular injury. So when you do these, once you do the reduction, you also have to do a neurovascular check. Anytime you apply a splint or a sling or anything like that, you should check for sensation in the fingertips, make a fist and close it, move your wrist up and down. And you should also check for either capillary refill or a radial pulse, whatever you can get at. The open reduction is usually reserved for any vascular insufficiency with a probable entrapped brachial artery, or patients unable to achieve reduction using the closed reduction method. Sometimes you'll pull these back into place, and there's such a comminuted or multiple fragment fracture that there's nothing for it to hang on to. So you pull it back into place, you put the splint on, you get the post-reduction x-ray, and it's just back where it was before, maybe a little bit better. So those are the ones that you know that you got to take to the OR. Flexion-type injuries account for about 5% of supracondylar fractures. The mechanism of injury usually involves a direct anterior force with anterior displacement of the distal fragment. Open fractures are relatively common due to the direct force. The type 1s, again, are non-displaced, treated with conservative immobilization in a flexed position. Type 2 is displaced with the anterior cortex still intact, and treatment requires the reduction in surgical management. Type 3 is displaced with both the anterior and posterior cortexes disrupted, and the distal fragments have migrated anteriorly and proximally, so it's come to the front and shortened, and are treated with reduction and surgical management. So when you look at these, this is the fat pad sign right here. Here's the fracture right here. When you look at this, see the angle here, see how straight that angle looks? In a normal elbow, this will be a little bit more anterior. So when you see this straightening like this, when you can draw a straight line right down it, and you see the fat pad signs, and you don't see a supracondylar fracture, just assume there is one. So this is the totally displaced posteriorly. Both the anterior and posterior cortexes are disrupted. These are the ones you got to pull back into place and pin them, or they're not going to hold. Mm-hmm. It's not dislocated. It's displaced. Oh. Okay, here the posterior cortex is disrupted, right here. Can you see that? There's a fat pad sign there, but see that right there? It might be hard to see on that. See where my arrow is? It's the posterior cortex is disrupted there. You can kind of trace the line as it comes right down this way here. Yeah. If there was a normal one up there, it'd be easier to see. So go online and look up normal elbow, and you'll see the difference. It's basically you bleed, there's fat there, and you bleed into the space underneath it, and it forces the fat pad out. So basically what you see in here is fluid and displacement of the fat pad. So this black here is fluid. It's blood. Right. Because the only things you're going to see on x-ray are bone, air, fat, and fluid. Those are the only 4 things that show up on x-ray. On the x-ray, you won't. Physical examination, it's probably going to be all swollen and tender. You're not going to be able to see this straightening. You only see it on x-ray. Medial epicondyle fractures, they're usually an avulsion-type fracture in children. The mechanism of injury usually is some type of direct blow or an elbow dislocation. They're non-displaced or minimally displaced. They're treated non-operatively, so you're going to splint those kids for like 4 to 6 weeks. Any fragment that's displaced greater than a centimeter or with valgus instability is treated with an ORIF, so you're going to have to pin that fracture back into place. Conservative management includes immobilization of the elbow in flexion, so a posterior splint with the thumb up in the air in the neutral position, and pronation, or actually pronation of the forearm with these. So you're going to turn the hand down. So this is a medial epicondyle fracture. You can see how that's probably displaced more than a centimeter. So normally what they'll do is they'll push that back in, and they'll put pins, 2 pins right through that to hold that. This is an adult too, because the growth plates have all closed. Radial head fractures, they're the most common of all elbow fractures. They occur with a Fouche type injury, a fall on an outstretched hand. It's characterized by point tenderness to palpation at the radial head and pain with supination and pronation. A lot of times these people won't be able to fully extend their elbow. The fractures can be really subtle on x-ray, so these are the ones that you're going to look for, that anterior displacement of the fat pad. Most of the time, the non-displaced ones are treated conservatively. What we do in the orthopedic office is put them in a sling for about 2 weeks, and after the first week, if they can tolerate it, we have them start doing gentle range of motion, and then we get them out of the sling at about 2 weeks and let them start moving it gently. No lifting, no activities, anything like that. But if you leave them in a sling for too long and the sling's too tight, their elbow's going to be stiff, and it's going to be a pain to get the range of motion back. Also, you can compress the ulnar nerve because it runs very superficially if you've got that sling on way too tight. No. You just hold the hand, try and get them out to full extension with their thumb up in the air, supinate and pronate.
If we're doing like motor muscle.
No, if you're just testing supination and pronation, you're just checking range of motion.
If you were doing motor, would you do it?
You really don't test motor for pronation and supination all that much, especially if you think they're fractured, because you could take a non-displaced fracture and make it a displaced fracture. Same way, I don't know if Professor Steiner talked about patella fractures and sunrise view x-rays. When you have a non-displaced transverse patella fracture, don't ever get a sunrise view x-ray, because you may take a non-surgical case and make it a surgical case, because when you get the sunrise view, you're going to flex that knee to past 90 degrees and you're going to shoot down. It looks like a sun coming up. That's what you're looking for. When you're doing that film, you're looking for where the patella sits in the groove of the femur that it should track. You're looking, does it sit laterally or does it sit medially? It's really not a good film for patella fractures. If you got a longitudinal fracture, it's not going to do anything. But if it's a transverse fracture, it can take a non-surgical case and make it a surgical case. That's a little aside, getting off the track. This is a radial head fracture right there. I don't know if you can see it, but you can see that little crack through the articular surface there. Looks like it kind of comes down this way and maybe down here a little bit as well. This is where you're going to see it most commonly when they have a radial head fracture, because what they do is they fall on the outstretched hand and it jams the radial head up into the humerus. Olecranon fractures, the mechanism of injury for those is either a direct blow or a Fouche type injury. The fracture is usually transverse, passing into the trochlear notch. The patients usually have an inability to extend the elbow fully. There's point tenderness to palpation over the olecranon. There's the ulnar nerve is commonly injured. The treatment, you have to really pad these well, because the olecranon is a bony process. And if you don't pad these well and just throw a posterior splint on them, you could start breaking down the skin there, and they could develop an osteomyelitis. They could get a necrosis of the joint. The other thing you can develop when you have fractures and you've got a pressure point is you can get what's called fracture blisters. So as you bleed into the area, if you put too much pressure on it, you basically develop a blister that's filled with blood. And if those rupture, it's an opening right into the joint. So you really have to pad these well over the olecranon, and then you want to splint the elbow with it flexed to about 70 degrees. So you don't want 90, you want just short of 90. And the forearm in the neutral position with the thumb up. So here's the olecranon fracture right here. You can see it's an intra-articular type fracture. It goes right into the joint. The Montagia fracture, it's a dislocation of the radial ulnar joint in association with a proximal forearm fracture. It's relatively uncommon. It accounts for about 5% of all forearm fractures. The X-ray finding of dislocation of the radial head is often subtle and it's easily missed. You need both the elbow and forearm X-rays for this if you have any clinical suspicion. The radial head dislocation can lead to radial nerve injury. Usually they present with pain and swelling over the proximal ulnar or the elbow. The radial head can be anywhere. It can be anterior, it can be posterior, or it can be anterior. So you kind of have to know where the radial head should be normally. So that's why you're going to do side to side. You're going to compare. So sometimes you may see the radial head here. Sometimes you may see it back here. It depends on how they dislocate. There's type 1 through 4. In type 1 and 4, the radial head can be palpated in the antecubital fossa. So this is your antecubital fossa. And posteriorly, so back here, in types 2 and 3, you always got to test the radial nerve function, flexion and extension of the wrist, flex and extend the fingers at the MCP joint especially, okay? The treatment is an emergent closed reduction. If you can't get it done, then they have to go to the OR and reduce it surgically and open. Usually these people are going to be in a long arm posterior splint or a long arm cast for 4 to 6 weeks, and then gentle range of motion of the elbow. This is the Montagia fracture, so you can see the proximal 1/3 of the ulnar is fractured here. The radial head, this is probably a type 1 or a type 4. I can't tell from just this X-ray. Type 1, it says it right there. But the radial head should be down here. So this is a dislocation right here. These are type 1s account for 60% of the fractures. It's an extension type injury, so you kind of fall like that. The shaft angulates anteriorly and the radial head angulates anteriorly. So if you go back, if you look to this, see how this is anteriorly, right? Because palms up is the anatomical position. In type 2 fractures, it accounts for 15% of them. It's a flexion type ulnar shaft. Flexion type injury, the ulnar shaft angulates posteriorly and the radial head dislocates posteriorly. So if you look here, here's the fracture of the ulnar. Here's the radial head down here. It's behind, this would be a lateral epicondyle, so it's behind the lateral epicondyle. The type 3 is the lateral type. The ulnar shaft angulates laterally and the radial head dislocates laterally. This isn't a great film, but you can see this is a kid because that's their humeral epiphysis right there. It's probably a young kid too because there's really no radial head here, so that's probably a less than 4-year-old kid. This is the type 4 Montagia fractures. I couldn't find a good X-ray of it, but it's a combined ulnar and radial shaft fracture with the radial head dislocating typically anteriorly, so you can see it up here. Lateral epicondylitis, this is something we've talked about. This is tendinous to palpation over the lateral epicondyle. So that's your extensor, right? Extensor muscles. It's an overuse injury of the cojoined tendons of the extensor muscles in the forearm. The other name for it is tennis elbow. The reason they call it the tennis elbow is the tennis players, as they come through, rotate over. So it's always more common in the dominant hand because it's an overuse type injury. The pain is usually worse against resistance with dorsiflexion. So when you're having them bring their hand up against resistance, they'll get pain right through here. The treatment's usually conservative with rest, ice, non-steroidals, and sometimes they'll put a Velcro wrist brace on these people to prevent them from doing too much extension. If that doesn't work, you can do a steroid injection in the elbow. You can only have 3 steroid injections in the elbow within a year before you have to go and have surgery. And they have this surgery. What they basically do is they go in and they lift the tendon up, and you basically scrape it off the bone, and then you trim away or debride the parts that are like calcified or rough edges or anything. Then you lay it back down, put a posterior splint on, leave them for about 2 weeks, and it starts to read here. You take them out of the splint at 2 weeks and begin gentle range of motion on it. Most of the orthopedic guys call it a voodoo surgery because nobody knows why it works, but it works. Usually the pain's gone within 4 to 6 weeks. Medial epicondylitis is referred to as golfer's elbow. So it's the medial equivalent of tennis elbow. The pain's at the medial epicondyle tendon of the flexor muscles. It's less common, but it's still an overuse syndrome. There's pain to palpation over the medial epicondyle and pain with resisted palmar flexion. So you're going to be like you're doing curls with a barbell. And the treatment is basically the same as tennis elbow. Olecranon bursitis. This is a relatively common thing. You see this quite a bit, whether you're in family practice, primary care, or emergency medicine. It's inflammation of the subcutaneous synovial line sac of the bursa that overlies the acromial process. Normally, you should not be able to palpate the bursa. And what it's doing is it's a little jelly-filled sac that allows you to lean on your elbows without having pain. It less commonly occurs from some type of infection. It's usually from some type of either repetitive trauma, like leaning on your elbows a lot, or for some type of trauma where you whack your elbow on something. Usually it's swollen and boggy, sometimes tender over the olecranon bursa. The skin temperature can be slightly increased, but it's not hot. That's due to the inflammation. The initial treatment is conservative with ice, NSAIDs. I always put an ACE wrap on these people because it helps to get the swelling down in the bursa, and do it for about 7 to 10 days. You always want to instruct them that if the ACE wrap feels too tight, take it off and rewrap it so it's not tight. If the conservative treatment fails, then you do an aspiration and an injection with a steroid. So this is what an olecranon bursitis looks like. You can see how swollen it is. It's slightly red, but if you push on that, it'll blanch, it'll turn white. One trick to know of what's infection and what's inflammation is if you take your finger and draw it over the area where it's red, if it's just inflammation, it'll turn white. If it's infection, it might lighten the color of the redness, but the redness never goes away completely. Septic olecranon bursitis is when they get infected. The most common cause is usually people that have like dry, cracked skin over the elbow and stuff gets in there, or they get some kind of a puncture wound. The most common bacteria is staph or MRSA. Usually when you examine these people, it's red, hot, swollen, and tender. They'll sometimes have pain with range of motion. Some of them with bigger infections usually will have a fever. Some of them will even have a white count. If they've got the white count and fever, those are the ones I usually admit. I'll at least talk to the ortho guys and see what they think, but a lot of times you want to get them in and get them on IV antibiotics. But the initial treatment for these is antibiotics with staph or MRSA coverage, so Keflex, doxycycline, or trimethoprim sulfamethoxazole. Some people are recommended both Keflex and either doxy or trimethoprim sulfamethoxazole. If it's unresponsive to the PO antibiotics, then you have to aspirate it and send it for a culture and sensitivity to identify the pathogens. And those are the people that usually end up on IV antibiotics. One thing you want to try to avoid is sticking a needle in these things, unless it's refractory to any kind of treatments. Because if you stick a needle in there and don't do a good enough prep, you can be introducing bacteria, especially if it's just a simple olecranon bursitis. Treat it conservatively. It may take 2 to 4 weeks for it to go away completely. But if it starts to go down, leave it alone. Don't needle it. Because all you're doing is opening yourself up for a whole new can of worms. Because even when you prep it and do a good scrub of it, you're only killing 99.8% of the bacteria. So if there's some bacteria there where you stick the needle in, you could be introducing bacteria into the joint. So you're better off to just stay away from it. If the ortho guy wants to stick a needle in it, more power to him. So this is what a septic olecranon bursitis looks like. See how red and hot it looks? And it's usually they're a little more swollen. And the redness kind of extends all the way down here. Usually that skin is hot to touch as well. Forearm fractures, the mechanism of injury is usually a direct blow or foosh type injury. The ones you see a lot of times in kids is they're on the monkey bars and they fall off and they land like that. Usually the deformity is obvious. It's some type of a roller coaster type appearance or obvious displacement. There can be fractures of both the radius and ulna or just one or the other. Usually the symptoms include pain, loss of supination and pronation, as well as flexion and extension of the elbow. There's pain to palpation at the fracture site. You need good neurovascular checks with these to assess for any kind of compartment syndrome, especially in crush type injuries. So this is a simple forearm fracture. This would be called minimally displaced. So there's like less than 10 degrees of angulation here, and both the radius and the ulna are fractured. So you can tell the force kind of came from the bottom up here, because you see where the exit is here, how it's angled a little bit. So this is somebody that probably fell onto their forearm. This is a Galeazzi's fracture. These are the foosh type injury ones. So both the radius and ulna are fractured. The radius is completely displaced and shortened. You could say that that's overriding or shortened. And the lateral cortex of the ulna is fractured. It looks like the medial cortex is fractured. The lateral cortex, it looks like it's still intact. And here, this is the lateral view. This is why you always want to get a lateral view, because this tells you that this is angulated. If you took this angle here, you're looking at probably 45 degrees of dorsal angulation with that displacement and shortening. This is a nightstick fracture. Nightstick fractures were common when the police used to beat them with the nightstick, especially like the union guys when they were trying to get rid of the unions back in whatever it was, the 20s, 30s, whatever that was. And you put your arm up like this to block it, and you get hit by the nightstick, so you get the fracture wherever. So it's a direct blow type fracture. This is a green stick fracture. It's common in kids. Usually it's the fall onto the outstretched hands. These are the ones, when you look at it, it looks like the roller coaster where it goes up and then the big dip down and then back up again. Wrist fractures. The most common mechanism of injury is a fall on an outstretched hand. The symptoms usually include pain at the fracture site, swelling, sometimes numbness and tingling. There is pain to palpation at the site of the fracture, and most of the times you can, if it's a big fracture, you can feel a step off or some type of deformity. Again, I'm going to beat a dead horse, but you need to do a good neurovascular check on all of these. Colles type fracture. Initially, a Colles type fracture was always known as a displaced fracture of the distal radius, as well as the ulnar styloid being fracture. Now they've kind of all come into one, everybody calls distal radius fractures Colles fracture. It's not the true definition of it, but everybody's calling them Colles fractures now. Usually the treatment with these is if they're displaced, you have to do a closed reduction where you use longitudinal traction. Most times what you do is what's called a hematoma block, where you'll take some 2% xylocaine or some marcaine, and you'll inject like 5 cc's. You'll go into the fracture site, draw back some blood, and then inject the marcaine, and you kind of move around. And you give that about 10 minutes, and it kind of numbs the area. Does it make it completely pain-free? No. But does it make it better for them? Yeah. Then you kind of hang the hand. It depends on what technique you like. They have these finger traps. You can put them in the finger traps. And then what you do is you're going to use one hand and pull down here, and the other hand here. You're going to get your thumb in behind the fracture, and you're going to pull up, and you're going to exaggerate the fracture. So you're going to make the displacement of the fracture worse, and then pull up. And as you pull up and push with your thumb, as you feel the fracture reduce, what you do is you flex the wrist and ulna deviate it, and that will usually pull it back into place. Then you've got to splint those right away, get a closed reduction film. The ones that you can't get reduced, they have these neat little plates now, and they reduce it in the OR, and they make a small incision that's like, I don't know, half an inch big at the most. They put the T-plate in, a few screws on the longitudinal axis, few screws on the transverse axis. And the best part about those, they're doing them on all younger people now because it reduces the amount of arthritis you're going to get later on. If you just do a closed reduction, you can be guaranteed that you're going to get some arthritis in that wrist at some point. So this is a displaced Colles fracture. This is somebody that's probably in an emergency department. When you're looking at them, you can see the fracture here. I would say he's probably got a fracture over by the ulna here as well. Here's the ulnar styloid fracture right here. That's the ulnar styloid, that tiny little dot there. And this is a comminuted, angulated, impacted distal radius fracture. So you can kind of see that this was probably a Fuchs type injury. If you look at this angle here, this belongs down here. So this is probably displaced at least 20 to 30 degrees. But if you look at this here, here's the outline of this. So it looks like this is impacted. And here's how you tell it. It's a comminuted type fracture. Here's 1, 2, at least 3 fragments. There may be a fracture going up into here too, so that's 4. So anytime it's in more than one plane, it's considered a comminuted type fracture. So this is a sugar tongue splint. You're going to do these on all wrist fractures, unless it's a tiny little buckle fracture on a kid, then you can use a Velcro splint. But in all wrist fractures, especially after a closed reduction, you're going to put these sugar tongue splints on, because if you notice, it comes up over the elbow, and you flex the elbow to 90 degrees. What that does is it keeps you from supinating and pronating. And that makes it so that if they can't supinate and pronate, it won't displace again on you. So that's a pretty common type thing. Some people put long arm posterior splints that come down into the middle of the hand, and it prevents them from supinating and pronating. But usually with this, they got a little bit more function. After you get them out of the sling, you want them to stop moving that elbow and just wearing this. This is the Colles fracture with the ORIF. The 3 screws here, I don't know how the hell he got 7 screws in there, but he got 7 screws in. The guys that I do them with put 4 maximum distally and 3 in here. Smith fracture is basically a reverse Colles, so you're going to fall with your wrist bent. So it's also called a reverse Colles. Usually the fracture fragment, the distal fragment of the radius will displace volarly, so it's going to be on the palmar side. The treatment is pretty much the same. It's closed reduction with longitudinal traction and extension. An ORIF is usually done with percutaneous pinning. So basically what you do is you pull it back out to place, and then you crisscross 2 pins to hold the fracture fragments in place. You can still move them a little bit if you do this, but if you splint them good, it's going to allow for that to heal. The reason you splint in the initial phase is to allow for swelling. If you just throw these people into casts and don't at least split the cast, you're better off with the splint, because they can loosen an ace bandage. If you put a cast on and they're at home and they call you at 2 or 3 o'clock in the morning, it's pretty hard to tell them to loosen a cast, because then you got to tell them to go to the ER. Then they're going to go to the ER, and you're going to get another call around 3:30 or 4 o'clock in the morning waking you up again, saying their cast is too tight, can I split it? Because nobody's going to split a cast without asking, or they shouldn't split a cast without asking, because they don't know what you've done. So here's the difference. Colles fracture and the Smith's fracture is with the wrist flexed. So here's what a Smith's fracture looks like on a plain film x-ray. You can kind of see it's comminuted here. This is displaced anteriorly or volarly. There's also fracture here through the distal ulnar as well. So with the Smith fracture, these are the finger traps that I was talking about. So you're going to get your thumb in behind here, and you're going to push up, and then you're going to have the traction. Your counter traction is going down. It depends on what you've got or what you're used to. Some people just push up with one hand, and they'll have somebody else pushing down with the other hand. Or sometimes if you can't get help, you have to use this little system with the weights. Scaphoid fractures. The mechanism of injury is a Fuchs-type injury. It's the most missed fracture in all of emergency medicine and pretty much in all of medicine. It may not always be present on an x-ray, so these are the ones that you have to re-x-ray in 7 to 10 days. Usually they'll have pain and swelling at the base of the thumb. The pain is worse with movement of the thumb. If you press on the anatomical snuff box, you get pain in that anatomical snuff box. First thing that should come to your mind is a scaphoid fracture. and you know you're going to be splinting them and repeating their x-ray in 7 to 10 days if it's negative. They'll also have pain with abduction and adduction as well, especially abduction because you're compressing the fragments, and that's of the wrist. When you do it, if you get snuff box tenderness, you also want to palpate the scaphoid on the volar surface, so on here, and then you're going to do what's called axial loading of the thumb, where you basically grab the thumb and you push it back in towards the scaphoid. So what you're trying to do is compress the fracture fragments. If you get pain with all three of those, you can be almost 99% assured that there's a fracture there, even without an x-ray. So any of these patients deserve an x-ray, and even if you don't see the fracture, you should treat it like it is a fracture, and they need a repeat x-ray in 10 days. A lot of times you'll see that the scaphoid fracture will have opened up by then. Anything that's fractured that's near the thumb will usually heal within 6 to 8 weeks, so the more distal it is, the more likely it is to heal. If there's a fracture at the waist of the scaphoid or proximal, it's less likely to heal. There's a lot of non-unions and necrotic fractures with those because there's not a real good blood supply. So here's a scaphoid fracture. That's more distally. This would be about the waist right here, and this would be the base down here. So you can see this one's a scaphoid waist fracture. This will probably go into non-union or some type of necrosis because the blood vessel comes in right about here. And it's only got one blood vessel that comes in. So again, there's another, that's at the waist of the scaphoid, and you can see there's avascular necrosis. If you look in here, you can see that the bone's starting to decay right through here. And there's a non-union type fracture there. The treatment with these is a thumb spica splint. And if it's a distal fracture, you always want to refer these to orthopedics. They're going to be in that splint for about 6 weeks. For waist or proximal fractures, you're going to use a thumb spica splint and extend it up with a sugar tong. So you'll do the thumb spica, but you'll bring it around just like a wrist type fracture. A lot of times these ones that are proximal or waist type fractures need to have a screw put in because they'll generate a non-union type fracture. Sometimes you even have to bone graft them for any comminuted fractures. So that's a picture of what a thumb spica splint looks like. So it's on the dorsal aspect. You don't go past the IP joint of the thumb. You want to let them be able to flex their thumb because otherwise they're not going to be able to hold a cup. So this is a screw. Here's the non-union fracture here. So they put a screw across to hold it. Scapholunate dissociation, it's the most common carpal instability. Again, the mechanism of injury is a Fuchs-type injury with the forearm in pronation, so they kind of land like this, and the wrist hyperextended, so it comes back. So there's pain and swelling are the two most common presenting symptoms. They'll feel a clicking or a clunking in their wrist. A lot of times these people don't come right away. They think they just have a sprain. Technically they do, but it's a bad sprain. It's a third-degree sprain. You'll get tenderness to palpation at the scapholunate interval, just distal to Lister's tubercle. The x-ray shows a widening of the scapholunate interval or scapholunate junction, depending on how old you are and who you learned it from. The normal interval is about 3 millimeters. Acute treatment is with open reduction and the dissociation and pinning the lunate to the scaphoid because that ligament is totally disrupted and it gives you an unstable wrist, so you have to pin those to make it stable again. In chronic scapholunate dissociation, the treatment's controversial, and it includes multiple procedures, including screws, pinning, all kinds of things. And unless you're in orthopedics, you really don't need to know a lot about it right now. So if you look here, here's the widening. This should be about 3 millimeters, so the lunate should be right over here. This is widened probably close to 1 centimeter. So this is what you do is you pin them together. So you got the crisscrossing pins there. This is like this is actually what's called a towel clamp. So that when you're in the OR, you're going to see them. They'll clamp towels together, and they'll use that. And they've got little points on it. So what you do is you make your incision. You go in and you get one of the little hooks into the scaphoid, the other one into the lunate, and you squeeze them. It's just like a pair of scissors type thing. You squeeze it together, unlock it, and hold it. where you like it, and you just put your pins across. Whole thing takes 20, 25 minutes with a good surgeon. You're in and you're out. It takes longer to set the case up than it does to do the case. Gamekeeper's thumb, it's also known as skier's thumb. It's an injury to the ulnar collateral ligament of the thumb. It's torn at the insertion site on the proximal phalanx, or there's an avulsion type fracture there. The mechanism of injury is fall onto the thumb with forced abduction and hyperextension of the proximal phalanx. Usually these people come in with pain and swelling and bruising around the base of the thumb and the thenar eminence. What you do is you need to stress that ulnar collateral ligament, so it's just like stressing a knee or an elbow. You're going to do a valgus type stress to it. And usually these people come in if they've had it for a while. They're having a hard time picking things up, tying their shoes, tearing a piece of paper. So sometimes you don't see these people until it's too late. And if they've just got an ulnar collateral ligament tear, the ligament usually retracts and it's too hard to find. It'll just kind of shrivel up because it doesn't have a great blood supply. So then basically you have to do a surgery where you have to take part of the tendon and recreate the ligament. There can either be fractures or tears of the ulnar collateral ligament. The fracture is usually an avulsion type fractures. In some cases, the aponeuroses of the adductor pollicis muscle becomes interposed between the bones of the metacarpal phalangeal joint and the torn ligament. That's called a Stener's lesion. I just thought it was cool because it sounded like Steiner, so I put it in there. Adequate healing can't occur because of the muscle in between there. Stener's lesions present in 80% of all ulnar collateral ligament ruptures without any fracture and fluoroscopic evaluation of the joint laxity. You don't really have to do fluoroscopic evaluation. It's nice if somebody can do it, like if you're in an orthopedic office that has fluoro and you can go in and stress that ulnar collateral ligament, that's great. But most times you can just feel it and it just opens wide up on you, unless some people have it on both of their thumbs. So that's why you do side to side. So it can be normal for them. With the avulsion type fractures, you're going to go in and pin that avulsion fracture back to stabilize the joint. So this is the one with the avulsion type fracture. If you can see it right through here, it's at the base of the proximal phalanx. This would just open wide when you do that. So you're checking the ulnar collateral ligament. So it's on the ulnar side of the thumb at the base. So here's the normal one here. Here's the torn ulnar collateral ligament here, and then the adductor pollicis muscle, aponeurosis, comes down in here. You can see it here and here, and the ligament gets trapped, and you can't find it. This is showing you how to do a valgus stress. So you got to stabilize the joint at this end, and then you're basically going to abduct here with this thumb, or do a valgus stress with this thumb. Bennett's fracture. This is another thumb type fracture. It's an intra-articular fracture at the base of the first metacarpal. So it's down here at the base of the thumb, just past the carpal bones, and it goes into the carpal metacarpal joint. It's usually an unstable fracture. It is the most common fracture of the thumb. It's almost always accompanied by subluxation or dislocation of the CMC joint. The mechanism of injury is to fall on the thumb or striking the thumb on a solid object. You see this a lot in people, especially the mountain bikers, fall off of their bike, go over the handles, and jam their thumb on the way down. These people have a hard time pinching, opposing their thumb, or picking things up with their index and thumb. So here's the metacarpal here. Here's the Bennett's fracture here. This is comminuted. You can see how that's displaced. This is probably, the joint's probably dislocated because it belongs back down here somewhere. The treatment with this in small avulsion fractures, not like that, without any instability, you're going to put them in a thumb spiker for 6 weeks with serial x-rays probably every 3 weeks. For any displacement of the trapeziometacarpal joint of 1 to 3 millimeters, you can do a closed reduction and then do a percutaneous pitting. So you're going to drill 2 pins through. You don't even have to open up the skin. You can just drill them right through. And you're going to pin that and thumb spiker them for 6 weeks. For anything bigger than 3 millimeters, like that last one, you're going to have to open that up, pin them, and put it back into place. Boxer's fracture. The mechanism of injury is punching a solid object with a closed fist. The fracture is at the fifth metacarpal head. Usually there's volar displacement. They have pain, swelling, and deformity. A lot of times they'll try and tell you that they fell and hit their hand like that. Nobody really believes them. On exam, there's tenderness at the fifth metacarpal head. There's flattening of the knuckle where you'll see the normal knuckles, and then the fifth one will just be flat. And if you palpate down here on the volar surface, you can feel the angulation of the fracture because it usually goes into the palm. They're also unable to fully extend at the fifth MCP joint. You always want to look at these for rotation to see, because if they're rotated, those are the ones you usually have to pin. Most of the time you have to do a closed reduction on these. So you basically do that. We do it actually in the ER. We don't even call orthopedics until we're done. What you're going to do is you're going to put an ulnar gutter splint on them. So the ulnar gutter splint comes along the ulnar aspect. You're going to include the fourth and fifth fingers. Once you get the splint on there and you get the ace wraps on to hold it, then you're going to take your hand like this and you're going to flex them to 90 degrees at the MCP joint. It hurts, and they're not going to like you, but you got to do it because what that does is that prevents that rotation if they don't already have it. In the rotated fractures, they have to take those and do either a percutaneous pinning, or now they have little screws that they're using. It depends on the surgeon. They'll do the closed reduction first, where they'll pull it back into place, and then put the pins across. The guys that use the screws usually will make a little cut, pull it so that they can see it's back into place, and then put their screw across. This is an ulnar gutter splint. You can see it here. They didn't quite get them to 90 degrees, but it's close enough. The other thing is you want to make sure that you leave them a little bit of range of motion of those fourth and fifth fingers. So at least the DIP joint should be out on both the fourth and fifth fingers. Finger dislocations can occur at any joint of the fingers, the DIP, the PIP, or the MCP. Just remember in your thumb, you don't have a PIP or a DIP, you only have an IP joint because there's only one joint besides the MCP joint. The dorsal PIP joint is the most common dislocation. The PIP dislocation, usually described as dorsal, volar, or lateral, depending on the direction of the PIP in relation to the proximal phalanx. You should do the reduction as soon as possible. The more they swell and the more the muscles tighten, the harder it is to get it back on a closed reduction. The metacarpal phalangeal joint is the most common dislocation of a joint in the thumb. Usually those go dorsally. The treatment for all of these is closed reduction and splinting. If there's fractures, sometimes they have to pin the fracture fragments. So that's one you'd call ortho for. So this is considered a dorsal dislocation of the PIP joint. So here's the proximal phalanx right here, and here's the dislocation. So here's your PIP joint, and it's dislocated dorsally. This is a DIP dislocation. Again, this is dorsally. So if it was over here, it would be volar. And if you saw it somewhere down on the side there, it would be lateral. This is an MCP joint dislocation of the thumb that you can see right there. Why don't we take like a 5-minute break, and then it'll probably take about another half hour to finish this. In that ballpark anyways.
What if there's a fracture that's really just like shattered? Like, do you just put a bunch in like an elbow? Because there's one time it's really just like really
Use
that's
plates.
it was just like
You
I
put a
couldn't even
plate
tell
on
what
either
was.
side.
Like, do they get all the way?
No, sometimes you take little tiny ones, you take them
The bone,
all the way, you send them to college.
or the bone, like maybe like
It'll take a while. But you use buttress plates on each side and put scoops. So but you got to be careful there, especially in elbow. You got to be careful with the weight, depending on where it is. Depends they have, if it's higher up, retrograde rods. You can kind of put a rest go here and put a rod up.
elbow replacement. Not really.
depends on the age. They're not gonna, she's in her 80s. They're not gonna. Even in the collies type, they're over 70 years old. They don't.
Not a matter.
They
Because
don't.
she couldn't, like, it was like,
Right, she's gonna lose
she couldn't
function no
even-
matter
well,
what
she
you do.
couldn't even straighten it, so the only X-ray I could get was like, got her enough on the table. Like,
As long as you get a lateral, the elbow, that's your money film. Lateral is always your money film.
yeah,
You can see any fracture on
the worst. And also, sugar tongue.
That's for wrist fractures. You're gonna
It's like when I used to do baby
stand
test,
here.
it was
See you see your hand here. Go down and up like this. If you're by yourself,
Where are they?
stuff. Have you seen the splinting material?
Yeah, no, I'm
You know
saying
how on
you
either,
should do
you know how on either side of it has like little tabs.
Yeah.
So if you cut it most of the way across, but leave one of those tabs in place, tab down into here,
Yeah.
and then you can put the middle finger across the hole. It'll slide and wrap it around.
But what I used to do for what they have me do is for radial, they would do a teardrop where you put a ball in it.
That's your stocking head. The under stocking head.
That was, well, but that's what we did.
That's where you trick her. And you're
It is,
Same with ulnar would be like,
the only got it was here.
but it was just, I'm saying if it was just an ulnar fracture, but it didn't.
Well, if you had an
maybe
ulnar
one.
fracture, if
I'm saying it was if it was like proximal.
you
or
gotta
distal
use a posterior.
ulnar. Or just a short arm,
The short arm one,
or just a normal short
they
arm.
can supinate and pronate.
And it makes
When you
sense.
supinate and pronate, it's the radius and ulnar, right? So all the movement like this, supinate, pronate, when you flex and extend, these bones aren't used very much.
So you cut the short.
I would put a post for for a distal ulnar fracture. I would put ulnar posterior fracture.
Okay.
Because that controls rotation. All from the elbow. None of the movements at the wrist, all at the elbow. The wrist, I isolate my wrist. It's not rotation. Because that's why you get the radial head. That's why the radial head articulates. Color. And that's where you get
driving in front of you is that car. Go the other way.
That's gonna be. They're a little more tender. Most of the simple. Hurt when you lean on your elbows. Your elbows seem swollen. Usually, when you feel it, it's squishy or hard. Yes. Okay.
Blood work right now. Oh, it's 11 o'clock. Right. 1 o'clock, it's lunch.
That'll be
I'm thinking Friday might be a zero day. If Joel comes through for Can I just wonder how long I wish it was some guy.
Oh,
Yeah.
Question was, the lady we have, I sent out my supplement on Saturday morning, and I asked her to respond.
Yeah,
to
I
me,
haven't
and-
gotten a bunch of them.
and she hasn't responded.
Who did you
I
have?
had this. Edison.
I would send it again.
I did again. Well, I mean, I sent her. I didn't send it again, but I just sent her another
Okay.
email just to make sure that she got it. She hasn't still responded. So I don't know.
Whether she gave, I'll see if I can, it was Davidson. Remember her first name? Was it Sherry?
Heather.
Heather Davidson, okay. I'll talk to Professor Steiner.
I mean, I have a proof that I did send it in time.
No, I believe you. I got, out of 10, I only got 2.
Yeah, because some people got responses from her.
Yeah.
From my group.
And you did, yeah.
And just me and 20 students.
Okay.
did not get it.
I gotta write that down so I forget it. Are you kidding me? I can barely walk.
We're
Like
gonna
football.
have a cheerleading section too.
Oh, yeah.
Spectator.
Oh yeah? I've been there. I did drug testing for the NCAAs there and for the Patriots. I did it for the NCAA lacrosse Final Four a few years back. So. Did you? Yeah, I think Syracuse. It was Syracuse, Duke, Cornell, and I think it was Hopkins was the other one. Cornell ended up winning. I think that was 4 years ago. 4 years ago. Yeah. Over Memorial Day weekend 4 years ago. No, they come in and pee in a cup, stand and watch them and process the pee. Same as for the Patriots. We did the same thing. They had to go into the room. You get the metabolites of steroids, of cocaine, heroin, things like that. Usually, like stuff like HGH has to be a blood draw, and that's usually gone out of your system. He didn't really. Yeah, in the initial test, they never caught it. But he wasn't doing steroids; he was doing EPO. So that EPO is not detectable. But what happens is your red blood cells, because you take the EPO, your red blood cells multiply. They give it to cancer patients. I think they give it to people with like ulcerative colitis and things like that sometimes too. Well, that was his claim, is that his was going to be elevated, trained at elevation. And then the other guy there, I forget the other guy, his teammate said that there was an unborn twin with him that didn't develop completely, and that's why his had always been elevated. They got great stories, but the technology's getting so much better in detecting it. But now it's they come up with better and better masking agents. So, I mean, I looked at these guys down there. We didn't have a positive test down at Gillette for the 2 years that I did it. And these guys, I mean, they had watermelon. You know, they couldn't even straighten their arms out. Their arms were so big. And then you look at guys like Tom Brady's skinny as a rail. You know, they got him down as like 200 pounds. Probably half of it is his bones because he's 6'4", 6'5". You know, he's skinny as a rail.
Yeah, I don't know how you take it up. Oh, because that's a battery underneath.
Yeah. You know what? They're all doing it. Don't kid yourself. They're all doing it. They're doing it. They just know how not to get caught. They know how not to get caught. So.
Yeah, just to get like a sense of...
All right, we're going to start up again. So tuft fractures are something you're going to see a lot, especially in an emergency room. This happens when people, they close their fingers in the car door, house door shuts on it, especially little kids. You see it quite a bit in people that hit themselves with the construction guys. They hit themselves with hammers or sledgehammers, things like that. It's the most common type of a distal phalanx fracture. You get these what's called a subungual hematoma or a subungual hemorrhage underneath the fingernail, and that's because in some way you've disrupted the skin of the fingernail bed. Usually if it's just a subungual hematoma, you can do what's called trephination. Some people use cautery pens. I don't like that because that burns when you do it. I just basically take like an 18 gauge needle, I put the needle down on there and I spin it back and forth until I put a little hole in the nail. You start to see the blood coming out. You want to probably put 2 holes at the base. You'll get some of the blood out, and if you do it acutely, like if they crush their finger that day and come in, you'll get the blood out and their pain will be relieved because the pressure's relieved beneath the nail. And some of these people, they'll come 2 or 3 days later and you do it and you get trickles of blood out, and most of the blood's congealed under there, so you just tell them to do warm soaks to get it out from underneath there. If there's any kind of a nail bed laceration, you have to remove the nail, so you got to do a digital block to numb their whole finger. And then you got to take the whole nail off, and you repair the nail bed laceration with absorbable suture, which is like a vicryl or a gut type suture. And then you have to take the fingernail and place it back underneath the eponychium. So you got to lift up and push it back under and throw a couple of sutures in. And what you're doing is you're keeping the eponychium open so that when the new nail grows in, it doesn't get deformed. Because if you don't do that, and you don't even need to put the nail back in, you can suture a piece of gauze into there. You can cut the aluminum, the packaging of the sutures comes in, and stick that underneath there. As long as that comes underneath there, you'll do it with absorbable sutures because they're gonna go away in about 7 or 10 days, and the nail will have already started to grow. And if you don't do that, the nail gets compressed and deformed, and it's sometimes painful coming through. So after you repair that nail bed, which is hard, when you go to tie the nail bed tissue, don't pull hard because it's very friable. And if you start to pull hard to tie your knot, all you're going to do is tear it and make a bigger hole. So just tie it loosely, approximate it, it'll heal pretty well. You also want to do neurovascular check, and you also want to check the tendons. Even though the tendon inserts here down at the DIP, you always want to do a tendon check on any finger injury. So you want flexion and extension. You're going to isolate every joint, the MCP, PIP, DIP, or MCP and IP of the thumb, and you want to make sure they got flexion and extension. So this is an x-ray of a tuft fracture. You can see it just kind of explodes out. This one's a little displaced down here. It's displaced palmally, and you can see how much swelling there is in the finger. This is a subungual hematoma. This is the bleeding underneath. So you can see this one's probably old because you can see how dark it is there. This is a fingernail bed laceration. So this is one of the ones you're going to have to take the actual nail off and repair it. What I would do instead of repairing the nail bed first, if you can see how it goes into the tissue on the side here, I would repair this first. I would put 2 non-absorbable sutures here, and that'll bring it back up into extension for you. Then take the nail off and repair the nail bed. But you always want to digital block these people. When you do a digital block, your nerves for your fingers run along the sides of the fingers, so right in here. So the way you do a digital block is you go into the web space. You use either 2% xylocaine or Marcaine, depending on what you're comfortable with, and you're going to give a total of 4 cc's. So you'd go in here and give 2 cc's, so 1 cc to the top, 1 cc to the bottom on either side of the finger. Or you can try and do a 360, so you'd start in the middle here, you'd go straight down at a perpendicular angle till you hit the bone, then pull back a little, give a little of the xylocaine, and then go medial and lateral on the dorsal side, and then flip them over and stick them again on the other side and do the same thing. I have better luck doing it that way because I know I get a 360. You got to wait about 10 or 15 minutes for that to take, but usually they have no pain. If you use 2% xylocaine, they get about 1 to 2 hours relief. If you use Marcaine or any of the longer bupivacaine, any of the longer acting ones, they're going to get 4 to 6 hours of relief of pain, sometimes even longer. So when you're doing trephination, you can see here, this is showing you the needle. You just drilling a hole through. You do it till you start to see blood come back through the hole. Then you want to make the hole a little bigger. So mallet finger, it occurs at the insertion of the terminal finger extensor mechanism into the dorsal portion of the distal phalanx. Usually it's caused by an axial loading to the tip of the finger, leading to forced flexion. So you jam your finger, bends it down quick at the DIP joint. You get this avulsion type injury, so the tendon pulls a piece of bone off. Usually the treatment for these is to splint them in full extension for 8 weeks. So they can't come out of that. They have to leave that on even when they shower. So you use a finger splint from the PIP up to the tip. You might want to come a little bit beyond the tip so that in case they do bang their finger again, but they have to be in full extension. They can't be dropping down or otherwise it's never going to heal. It's got to be in full extension. Surgical repairs recommended for fractures with greater than 30% of the interarticular surface and those associated with any kind of volar subluxation. So if you look at this fracture and you get the lateral view of the finger and you see that the distal phalanx is displaced volarly or anteriorly, whatever you want to call it, then those are the people that are going to need surgery because that's a complete disruption of the tendon. So here's what mallet finger looks like. They won't be able to extend at the DIP joint. You can see here's the extensor tendon, and it just ripped off a piece of bone out here on the DP. This is the mallet finger on the x-ray, so there's the avulsion, but you see how this is displaced volarly? So this is probably 50% displaced volarly. This is one of the ones that's going to need to be pinned. Flexor digitorum profundus avulsion, it inserts at the volar surface of the distal phalanx. The mechanism of injury is forced hyperextension of the flexed DIP joint. It's commonly referred to as jersey finger. So you see it in people that play a tackling type sport where you got to grab onto the jersey, and as they grab on, the guy starts to pull away, so they get a flexed, their finger is flexed, and they get a forced hyperextension. The x-ray is going to show an avulsion type fracture. These usually need surgical referral right away because you don't need full extension of the DIP joint for function. You do need flexion because you can't grab on. Extension you can get away with without. Flexion you can't get away without. So here's the avulsion fracture on the volar surface here. That's the flexor digitorum profundus avulsion fracture. Boutonniere's deformity. It's an injury to the tendon that prevents full extension at the PIP joint. I've got one because I dislocated my finger one day and I popped it back into place and I didn't realize that there was probably a disruption of the tendon there. And I just left it, and it won't straighten out there. So what happens is you get that boutonniere type thing. It's from, I guess they were tailors or something back in the old days. It's a French type thing. So it comes from a forceful blow to a flex finger or some type of a laceration through the tendon. Usually you get swelling, pain, and a deformity at the PIP joint. You need an x-ray to see if there's any kind of fracture. There's not always fractures with these. It can just be the tendon ruptures on its own. Non-surgical treatment is splinting in full extension at the PIP joint. So when you're going to splint the DP joint, you have to come back the DIP joint, you have to come back to just a little bit past the PIP joint. If you're splinting the PIP joint, you have to come back to past the MCP joint. So you have to get that joint below it. And that's going to keep you in full extension. Surgical treatment's indicated if the deformity results from rheumatoid arthritis, any kind of tendon laceration, or a displaced fracture. So that's what a boutonniere's deformity looks like. Swan neck deformity, it's a hyperextended PIP and flexed DIP joint. Rheumatoid arthritis is the most common cause. Non-surgical treatment requires hand therapy and splinting to restore the balance and the structures of the fingers, and usually they're splinted for about 6 weeks. It's not always effective, however, though. Surgical repair can restore the balance of the structures around the PIP joints in joints that aren't stiff. So if they've got flexion and extension at the joint, the surgery is probably going to work. If not, they usually just fuse the joint because it's already stiff anyways. So there's your swan neck deformity with the hyperextension at the PIP and the flexion at the DIP joint. Those will be on your boards. Those are two things that are usually on the boards: swan neck deformity, boot and ears deformity. Trigger finger, I think this is something that we talked about in lab. The tendon on the flexor surface gets thickened and nodules form at the A1 pulley. Your A1 pulley is right here at the metacarpal heads. The tendon gets stuck as it goes to, and has to be pulled in. So when you flex, the tendon shortens and it gets stuck because of the nodules or the thickening, and it can't extend. So you see these people, it's usually the ring finger and it's stuck down like this, and they'll have to take it and snap it back out. It's more common in women, usually 40 to 60 years old. They don't really know what causes it except for the thickening, or they don't know why that occurs. It's more common in people with diabetes and rheumatoid arthritis. The fourth finger is most common, but it can occur in any finger or thumb. The treatment's usually conservative at the start with rest and non-steroidals, but it's not always effective. You can do a steroid injection into the tendon sheath, and that's usually more successful. Sometimes it will come back, though. But most times they'll get at least 6 months if the steroid injection works the first time. Surgery is the last option, so they'll go in and they'll just open up the tendon sheath to allow the tendon to flow freely. And they'll do that in people that have had at least 2 steroid injections that failed. So there's the trigger finger there. It's flexed and they can't extend it. When you're going to do the trigger finger injection, basically what you have to do is you're going to find the metacarpal head and you're going to push down and have them flex their finger a little bit, and you'll feel the tendon come up underneath your finger, and then you'll have them extend out, and you'll give a little bit of numbing medicine, and then you'll go in and you'll feel the pop as you get inside the tendon sheath. Then you want to go in and pull back just a little bit, make sure you don't get any blood back, and then just kind of inject slowly with the steroid. Kenalog, 40 milligrams, methylprednisolone, 40 milligrams. Those are the 2 most common ones used, plus a little bit of the Novocaine that helps numb it up. Not Novocaine, lidocaine, xylocaine. Dupuytren's contracture. It's a fixed flexion contracture of the hand. It's most common in the 4th and 5th fingers. You get nodular thickening of the palmar-fascial cords, so right through here. That causes the contracture of the fingers. Males are more likely to get it than females. It's bilateral in just under 50% of the patients. Surgical release is the definitive treatment. So you can see the thickening of the palmar-fascial cords here. So they get that flexion contracture of their finger. They look like some of the frat guys. They're doing that. Osteoarthritis of the hand and wrist. It's a common disorder in the elderly. It's seen on x-ray in greater than 80% of the patients older than 65. Not all of them are going to be symptomatic. Males are usually greater than females in patients less than 45, and females greater than males in patients over 45. The DIP joint occurs more often than the PIP, or the first carpal metacarpal joint. It can be the result of previous trauma, generalized osteoarthritis, avascular necrosis, or some unknown etiology. Heberdine's nodes, Heberdine's and Schwann nodes, that's one other thing you should know for the boards as well. Those pop up every so often. The Heberdine's nodes Heberdine's and Bouchard's nodes, not Schwann. Heberdine's nodes occur at the DIP joint. Bouchard's nodes occur at the PIP joint. The osteophytes can cause angular deformity. So the osteophytes are the actual arthritis, the bony production that gives you the arthritis, and it stretches the ligaments and tendons. Most people with this in their hands get loss of range of motion. They can't grip onto things. They have a hard time opening doorknobs. They have a hard time like scissors, anything like that. And they'll get some weakness in their hands as well. So these are the Heberdine and Bouchard nodes. Conservative treatment is usually the way to go with these people. You're going to use NSAIDs, splinting, occupational therapy, and sometimes assisted devices which help to keep their hands in a position. In the elderly, you got to be careful with the NSAIDs. You want to decrease the dose and decrease the frequency. Anything over 10 days at a time puts your kidneys at risk with the NSAIDs. I mean, there's plenty of people out there that are taking it, every day of the week, but they're only taking 1 or 2 doses. If you're taking, the maximum 2,400 milligrams of ibuprofen a day, and you're taking it for a year or two, you're at risk for renal disease, for renal failure from the ibuprofen. Steroid injections usually aren't that helpful. There's surgical procedures, including a fusion or an arthrodesis, and that's the last resort to relieve any pain. And the rate of non-union is high in these people at about 15% or greater. First carpal-metacarpal joint, or the thumb, osteoarthritis. It affects a lot of postmenopausal women. The pain's aggravated by any pinching or grasping maneuvers, such as opening jars. These people get a lot of pain at night when they're trying to sleep. They'll have weakness in their hand. You'll see an obvious deformity at the joint. There's tenderness and crepitus at the first carpal-metacarpal joint. Sometimes steroid injections are helpful because it's a bigger joint, so you can get in there a little easier with the needle and give them the steroid. Sometimes they'll get relief with that, sometimes they won't. Conservative treatment is nonsteroidals. You can splint them with a thumb spiker in acute flares. Surgical treatment, basically, they're calling it thumb replacement surgery. But what they do is they go in and they remove the trapezium and they take some up, they scrape off some of the tendon and they pack the area with the tendon just to act as like a shock absorber or a cushion to simulate the cartilage that was there that's been destroyed. Sometimes they have to fuse those, which will leave you with a stiff thumb on that side. De Quervain's tendonitis, this one's definitely on the boards, I can tell you that. It's first dorsal compartment tenosynovitis, or inflammation of the tendon sheath. It's an overuse syndrome of the thumb. The pain is usually at the anatomical snuff box and the wrist, so you can get confused with this about a scaphoid type fracture. These people usually have no sign of any injury. Usually it's something that comes on gradually and gets worse. Sometimes they wake up with it in the morning. It's usually people that do a lot of work with their hands, people that are typing a lot, things like that. Sometimes if you put your fingers over the wrist here, right at the radial styloid, and have them flex and extend their thumb, you can feel this squeaking or crepitus type sensation underneath there. The Finkelstein's test is always positive in this. So in case you don't remember what the Finkelstein's test is you put your thumb down into the palm of your hand, make a fist, and you ulna deviate. They'll get pain with that. Usually you treat these conservatively with a thumb spiker splint or a thumb spiker brace. They have these little Velcro thumb spiker braces that are a lot more light than a thumb spiker splint. Some anti-inflammatories, ice and rest. Usually if they fail, they can give you a cortisone injection or a steroid injection, whatever you want to call it, into the de Quervain's tendon. Again, it's usually you can only get 2 of these. The one thing you don't like to inject steroids that much into the areas of tendons because there's a higher incidence of rupture of the tendon. So you'll see that nobody will ever give a steroid injection into a patella tendon or an Achilles tendon because it's under high tension. Sometimes they do surgery on these. It's very similar to the trigger finger surgery where you just make about a 1-inch cut and you go in and you pick up the sheath and you open up the sheath and that lets the tendon move freely so it gets rid of the pain. Carpal tunnel syndrome, definitely on the boards. It's a median nerve compression at the carpal ligament. There's a history of pain and numbness in the median nerve distribution of the index, middle finger, and part of the thumb, and sometimes half of the ring finger. It can occur in patients that use their hands for their activity. People that are on computers a lot are more prone to get it. People that sleep like this with their wrists flexed are more likely to get it. There's a higher incidence in people with diabetes, thyroid disease, and pregnant women due to the inflammation in their hands. When you look at these people, the first place you should look is at the thenar eminence. People that have long-term carpal tunnel syndrome, the thenar eminence will be flattened or gone. They'll also have decreased sensation to pinprick in the median nerve distribution. They get a lot of pain at night and numbness when they sleep. Usually they'll have weakness in that hand. They'll have a positive Phelan's test where you flex or you do this, whichever way, or a Tennell's sign where you tap and they'll feel like there's fire shooting out into their fingers. The gold standard for diagnosis is an EMG. Usually you start with conservative treatment with Velcro wrist splints to wear at night. It keeps them in a little bit of hyperextension. It doesn't let them flex and compress the median nerve. Sometimes you can do steroid injections on these. Those are kind of like a last resort before you go to surgery to see if it works. The definitive treatment is carpal tunnel release surgery, where they make a cut in here, and basically what you do is you go in and you elevate the flexor retinaculum, and you take your scissors or you take a scalpel and you just split the flexor retinaculum, and that decompresses the median nerve. Again, it's like a 20, 25-minute surgery that takes longer to set up than it does to actually do. So here's your median nerve through here. It gets compressed at the wrist. This is your median nerve distribution here. Here's what thenar atrophy looks like. You can see how it's gone there. You can see it's starting to go here. So this is the carpal tunnel release. So basically you've just split the flexor retinaculum here and let the median nerve fly free. Cubital tunnel syndrome is ulnar nerve compression at the elbow in the ulnar groove. These people get pain and paresthesias over the ulnar nerve distribution in the fifth finger and half of the fourth finger. Pain's worse at night. They can get hand weakness. They can get pain that's worse when their elbow's flexed. Sometimes it's related to trauma. You hear about it happening in pitchers a lot, and what they do is they go in and they do an ulnar nerve transposition where they gently distract the nerve out of the ulnar groove. They open up the groove, they burr it away, and then they place it back down in there. You can get atrophy of the intrinsic muscles of the hand, so they won't be able to spread their fingers apart. They'll get a positive Tenel sign at the ulnar groove. A lot of times what you do is initially people who aren't major league pitchers or major league hope-to-be pitchers is you splint them so that they can't flex at night when they sleep. So you want them out. You don't want them coming up. And they get hand therapy, things like that. Surgical decompression and ulnar nerve transplantation is for those who fail conservative treatment. Paronychia. This is something you see a lot of in emergency medicine, is these types of infections. It's a soft tissue infection localized to the proximal or lateral nail fold. They usually have a fluctuant mass or visible pulse. They have redness, pain, swelling, and tenderness to palpation. Staph aureus and MRSA are the two most common. The definitive treatment is incision and drainage, or I&D for short. So these are the people you're going to want a digital block first. When you do that I&D, you want to get a culture and send it for culture and sensitivities of the bacteria. Usually, you're going to cover these people with antibiotics for staph and MRSA for the first 5 days. So cephalexin, doxycycline, and trimethoprim sulfamethoxazole. This is what a paronychia looks like. I digital block these people first. Some people don't bother to digital block them. They just take the scalpel, and all you basically got to do is slide it in here right along the nail bed, and the pus just starts to come out. But you got to make sure you squeeze all the pus out of there, because if you don't get it all out, it's just going to reform again. So this kind of shows you what you do. You just basically you're lifting up that area and rupturing the pus pocket. A felon's a little harder. It's a closed space infection of the pulp of the finger, so there's all the little closed spaces in the pulp. Staph is the most common. If untreated, it can lead to decreased blood flow and necrosis of the skin. Tiny little wooden or metal splinters, minor cuts account for about 50% of the causes, but the other 50% is unknown. It's characterized by these people come in, their finger is just throbbing, and it's really tight and tense when you push on it. They pull away as soon as you push on it, and they'll have a lot of swelling there as well, and that's at the pulp right here on the fingertip. So the best way to do these is a longitudinal incision where you go the long way. You don't want to cross the DIP joint. You'll see the pus will start to come out. You got to kind of squeeze it out. Some people use lateral or transverse, so they'll come in from one of the sides and they push it until they're all the way through to the other side. The only thing is when you do that lateral incision and come out through the other side, a lot of times that's where the nerve is running. So these people will have problems with throbbing pain afterwards because you've transected a nerve. The transverse ones, you got to be careful of those because you don't know where the tendon's inserting, and if you do a transverse opening on the volar surface, you could be getting a flexor tendon. You can disrupt the neurovascular bundles, and you can have a numb finger, basically. The other way they used to do them is what's called a fish mouth incision, where you would start up here and just basically open up all the way around at the top so that you could peel it back. And they've stopped doing that because they lead to unstable, painful fingertips. You have to pack these with small gauze. And then you're going to change that gauze every 2 to 3 days until all the pus is gone out of there. Because there's all these tiny little areas in the pulp that you got to get the pus out of. These people are all going to need antibiotics. I would initially give them a dose of an IV antibiotics, maybe something like a Rocephin, ceftriaxone, something like that, something for staph coverage, and then send them out on PO, doxycycline, and cephalexin, so that you cover the staph, and you want to cover MRSA. MRSA is usually most susceptible to doxycycline and trimethoprim sulfamethoxazole. A lot of the new big gun drugs MRSA is resistant to, stuff like levofloxacin, ciprofloxacin, even Rocephin. A lot of times it's resistant to as well. So this is what a felon looks like. You can see how tense, painful, and swollen that looks. That looks like the pus pocket right there, so that's right in the tip. So this is the volar longitudinal incision that you would do like this, and you basically got to go in with a Kelly clamp and open it up. You got to open up the whole compartment there and get all the pus out of there. These ones here, where you went on the sides and then pushed through, these are all the ones that they're saying to avoid now, that this is the best one to do. Herpetic whitlow. This is a viral infection. It's also known as digital herpes. It's common in kids. It's self-spread from the lips, so if they get the herpes sore on their lips from sucking their thumb or touching sores that are open, they can spread it to their fingers. Usually the skin is cracked on the finger when they get this. You can also see it in people that work in dental offices. It's more common in. It's pretty painful, and it looks like shingles on a finger. It's self-limiting. It usually lasts about 2 to 3 weeks. You can use antivirals, and that may shorten the course. So something like valcyclovir or acyclovir, things like that. I like acyclovir because it's only 3 times a day, and acyclovir is 5 times a day. So there's a little more compliance with the Valtrex. It's a little more expensive, but there's better compliance with it. And then you want to make sure that these people know that they shouldn't be touching other people that have open, cracked skin. So you can kind of see that's what it looks like. That's herpetic whitlows. So it looks a lot like shingles of the finger. Compartment syndrome. This is another can't miss. This is one of the reasons why you should always do a neurovascular check on people. It's caused by any kind of crush injury. It can also be caused by people putting on their ACE bandages way too tight, or people that put on too tight of a cast or a splint. It can occur in any of the long bones, forearm, the humerus, the tibia, or the femur. There's the 5 Ps. It's pain out of proportion to what you'd expect. So you may see these people that they come in with crush injuries. They got a little bit of swelling, but it's very tense, and they're in extreme pain when you see these. We had a guy, probably, 4 or 5 years ago from a car accident. He had a big humerus fracture, and we went in, and they had medicated him up the wazoo. I mean, by the time we got there, he'd been there probably an hour and a half before we got there, and he had, I think it was like 6 milligrams of hydromorphone by that time, plus 4 milligrams of morphine. And he was still in agony, and he was just thrashing around. But his fingertips were like dusky. They were starting to go pale, and he had some numbness and tingling in the fingers of his hand. And when you felt his pulse on one side, on the left side, which was the affected side, it wasn't great, but it was there. But when you felt the other side, it was bounding. And when you listened with the Doppler, it was monophasic, or one sound, versus the biphasic, or 2 sounds we heard on the right. So we shipped him into Boston Medical Center to the trauma center quick, because he needed to have a fasciotomy. He needed to have all those compartments opened up. Usually pulsiosis is a late sign, as well as paralysis. Paralysis is usually, there's probably no coming back from the paralysis with the compartment syndrome. So what they do is they hook up a needle to a transducer and it gets plugged into like a blood pressure type machine, and you have to stick it into the compartment. And you stick it into the compartment, and any measurement of pressure greater than 30 millimeters of mercury is considered high. So it's an absolute emergency, and it has to be treated immediately with a surgical decompression by a fasciotomy. So when you do a fasciotomy, that's basically what you got to do. You basically fillet them. You got to open up all the compartments because you got to release all that pressure. Otherwise, they have a chance that they'll lose that limb. I think that's it. Yep. Normal pulse, 5 days.
And the instructor's looking at you.
Very interesting.
Be ready to sort of pulse.
Really dairy. Yeah, I don't know dairy.
Well, you know, may
Very busy.
vascular thrombosis.
Get home and look, I got so quick.
I gotta call him.
I need you to rein me back in though, because I don't know what.
Yeah, I ended up doing it at a hotel. Well, not my wedding. But the reception was at the hotel, and a lot of had a like dentist's family that are from the right there. It was really nice. I have to say, other than the people that drank too much, it was actually really nice to the elderly. Because when they got tired, I know, like my parents should have just bucked up and
Have like a little powwow, see like what direction you go. Yeah, you know it.
Talking about the process.
Were we talking about this? You were saying like.
oh,
Yeah. Well, and they said their sister totally dropped
Only
the ball.
minimally related.
yeah. I totally threw my sister and my mom off, but you know what? It was the right decision for me to have friends.
So if you're doing sensory, you should go over
My
there.
sister was right doing My sister said, she's like, send me numbers. She set up an appointment. She sent me. She was like, all right, when you're ready.
Bicep. Depends on what.
My mom.
Don't worry, Clin, I won't drop the ball.
And it was
It should be a focused mode. You do need to stop first. If the light is intact,
okay, back to
I'll wear a dress.
dermatome, the dermatome, and the bicep dermatome. Don't ask me what level it is.
I know so.
Yeah, I know this is really my pistol grip approach.
So what is it? This was all like sitting on my desk when I
You're like, oh, let's take the moral high ground.
Yeah. Oh, you want to eat downstairs? Okay.
Depending on how it's done.
Here, wherever.
You know, in the lab.
20-minute brain break.
I didn't.
Here, Clin, give me your thumb.
Side in abduction. If you get this and their arm starts to drop,
Good one.
that's a torn
Here's a
vertebra.
good one. Yeah. Ooh, look at that one. Got an S.
Now, what is that supposed to do? Basketball? Jamming?
And then Dad's like, yeah, it's cool. You just jam
Basketball is all
your finger.
jamming.
He said I jam my finger, but I didn't, obviously.
I did that for 3 hours. Yeah, but you know what, when you first do it and it's slow and you can't tell, like,
I know, I tuned in every now and then. It was
Yeah,
like,
but it's
that is still boring.
It's kind of hard. It felt weird.
I needed
I asked
I needed pinky
that's what I clued into those
I wasn't
things.
very happy with it.
Oh,
But I would build it up. I would just
Usually you'll get
nice.
pain.
Felt better.
I know one or two special tests. You guys are staying there?
Yep. I'm staying here. What am I doing?
All I've been doing
You'll be fine.
is sitting back here and reading it.
Huh?
I've been sitting back here.
I'm gonna go for a run.
I'm multitasking. I was also
I'll see you, but
highlighting stuff. I just kept reading through. That's the hardest one. Longest.
I know, I really just started it. I mean, we went through it on Saturday while we were here, but it's only long and choppy. So today is the very first day that we're reading I know, you know what, the neuro thing came together quicker for me than I thought it would, so I'm sure it'll be the one.
Well, the neuro and the musculoskeletal are like so similar.
No, I don't know, I don't think they're that much.
They're gonna be like two kidney and ankle.
The only thing that's similar is it's the motor testing.
Yeah, that's the point.
Yeah, but even
Well,
that,
the
the
motor
muscle
testing
motor
of
or
everything.
But if you have to do passive range of
But they're not gonna
all
do that,
that
like,
is different.
expect everything. That's how
Solar.
and you're expecting for the same. Yeah, so that's right.
Internal and external. I don't know.
dinner? You have dinner?
I had my lunch for dinner.
Coming?
Yeah.
Lo siento.
Right.
Actually, you're technically serving.
Should I bring all my stuff? Because my stuff stays here.
I'm bringing mine.
You're bringing yours?
I am.
Said Lo siento, señorita.
Actually, everyone else is like still here.
Yeah, you're fine.
I'm just gonna leave it here since the auntie.
You think it'll be okay?
Yeah, I'm just bringing down my lunch.
All right. Yeah, I don't want to look at anything right now.
I'll see you. I was like, I know.
No, we just kind of like eat. I'll bring my purse with me just in case I'm not leaving that around. Are they coming back later? Here, huh? I'm a little concerned because they think the two are very similar. So, like, I don't think the neuro and the muscle is similar.
Wait, what? Someone said there's one.
So they're really like almost the same thing, and I'm like,
Well, parts overlap, but.
I'm sure they're fine. I'm sure they practice together and stuff. So.
Oh,
I'm
yeah,
sure
this
they're fine.
weekend. Yeah. We started so far in advance, like.
I
3
know.
weeks
That's
out,
why I
doing
feel a
that
little.
and stuff. Yeah, I know.
But it is what it is. You can only do the best you can do.
Yeah, and they don't give us like an infinite amount of time to.
Oh, there's too many things.
Yeah. Yeah, they just give us.
Just sitting over there.
I saw the list, but I
still
don't.
have to finish that farm quiz. I only have like 6 questions.
Boys,
Oh, I finished it.
Did
How
you?
many questions?
Okay. I think I'm good.
That's the truth.
I mean,
And then I had
That's
to
not
submit it
bad.
again, but then I got
then you can go
100.
back. And usually, like when you get one wrong, like you usually figure out like
Yeah,
it's
like, usually
between
between two of them.
So you're like, okay, I'll pick the other one.
I would never want to do that. You gotta think.
So I did it again and I got 100 though. So,
Oh, that's good.
yeah, so I'm all done with that. That's off my list.
All right. I may
All I have to do is.
ping you in that.
Oh, yeah, just ask.
If I submit it and I get it's wrong.
Comes road.
Yeah.
You know, you're a
Yeah, I did
technician
that.
more than a technologist.
All I have to do, I have to write our paper tomorrow for that.
My group
we're getting
together and doing that after class on Wednesday. We're just gonna do it together.
Oh, really? Yeah, because it's due Thursday, right?
She's fighting with herself up again.
Yeah, I'm gonna write
So I
it tomorrow
told
and then
them
just
come
email it to them.
hell or high water, we have to do it Wednesday.
Yeah.
It only has to be 3 pages.
pages.
Double spaces, like nothing.
Are you allowed to just put your entire case in it too? Like, take up one whole page?
I'm guessing not. I mean, that would be like a whole page, and then you'd only have like a half a page of.
Maybe I'll put it small print on top, so it'll
would
take up
just
like a fourth of a
summarize
page, like and then I'll start the actual paper line, so it's not really. It won't really be like counting towards the pages. But.
I make sure they had my note because I missed one. I keep it in my station, and the doctor wrote my note, but I hadn't received it yet, so I got to get it to him.
Oh, I need to get mine from my phone. You reminded me. Yeah, I know. I don't want to. I emailed.
Yeah.
So I didn't want to not.
Never know what I'm gonna get. But
Just know them. You know, they may ask you to do like 2 or 3 of them.
like, I'm saying like,
Demonstrate 2 or 3. And tell me why you're doing it.
like I've been home 6 and plan. Or whatnot. I want to see a doc for another person like, I'm gonna show you so-and-so for this. And what was
It's gonna be,
for? And what was
it's gonna be on the special test. It's gonna be personal preference.
42 neural tests.
Show me 2, show me 3, show me this one, show me that one, whatever. Yeah. Depends on who it is and what they want. That way you gotta know everything. But you know, you're preparing for it.
What's gonna happen?
Screw it out.
I mean, the amount of special tests, like neuro, every time they're like, "All right, talk about some special tests." I'm like, "For what? Would they have to say?" If
Have
you
diarrhea of the mouth.
Fine. Last time I overtalked John, everybody around.
I got
Then
kicked out of the
they'll
room
just
last
tell you
time
to
I
shut
did
up.
that. That's what happened. She was like, "You're done." And I was
Then
like,
you
"No,
know
but
you don't know. But I know more. Then you know that you got it, then you know you got all the points.
Is it going to be like it was last time, where it's
Yep.
going to be like you're going to do like GI, like peripheral vascular, and then you're going to do like neuro and musculoskeletal?
Could be.
Could be, I love it.
I'm just scared that it's gonna be like I'm gonna get all musculoskeletal, or I'll get 2 neuro. Is it likely?
Probably not.